Dr. Anum Saeed. I'm a cardiology fellow at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, and I'm part of the Circulation COVID-19 team. Today, I'm joined by Dr. Faisal Masud, who's a critical care intensivist and the medical director of the Center of Critical Care at the Houston Methodist Hospital in Houston, Texas. Dr. Masud, thank you so much for joining us.
Thank you, Dr. Saeed. It's my pleasure to be here. I'm happy to have a dialogue with you.
We appreciate you being part of our initiative, Circulation COVID Updates from the Frontline. We wanted to get your perspective on how your center and region have initiated this battle towards COVID-19 from a virtual ICU perspective, especially coming from a cardiovascular perspective. So could you please explain how the tele-ICU or virtual ICU framework that has been tried out at your large tertiary care medical center?
So virtual ICU has become quite a bit much more utilized in the intensive care units in the country, especially in the larger medical centers like Emory and other places. And that has grown over the last 10 years. You know, and in this, the rationale was how best we can utilize all the informatics, the decision support and algorithms to predict, especially in the hemodynamic profile, all the algorithm playing for the cardiac patient, which some of them have the most rich data. So in this COVID environment, you know, one of the biggest advantage really is that we have to not only provide world-class care to patients, but we have to protect the healthcare worker. And we have to be mindful of PPE also. So the virtual ICU, really, it fills a gap which exists. So with the virtual ICU cameras, with all the data being fed into the virtual hub, you can analyze all the hemodynamic profile, all the alerts can come up, you can zoom in, and nowadays the technology is so good that you can actually look at the pupil size. You can coordinate the care with the bedside team and not that everybody has to go in. For example, an alarm comes in, the nurse doesn't have to jump in, the critical care doctor doesn't have to jump in, the virtual physician or the virtual RN can look at it and kind of guide, is it real or not real? They can look at the drifts and everything. So it's really a teamwork for the critical care team, the bedside team and the virtual team to work together to provide in these very challenging patients who are very complex, and yet the concern for healthcare team worker exposure and PPE is relevant. So I'm hoping that it is filling up the gap and need which exists.
Dr. Masud, could you explain what is the flow of a typical virtual ICU, in particularly from a cardiovascular perspective in these COVID-19 patients?
COVID-19 patients, as you know, when they come to the intensive care unit, are more than likely are already intubated or about to get intubated. Quite a few of them have a cardiac element, cardiomyopathy or myocarditis. Quite a few of them are exhibiting septic shock phase. So the virtual ICU team and the telecritical care team are already managing from time zero. They are getting all the data parameters. They help the bedside team with inotrope, vasopressor, titrating, starting, managing with that. So that's really from time zero. Not only that, but they help them to look at trends. Can we wean off drips? Can we deteriorating? Are we need more escalating therapy? And another advantage of the virtual ICU team, especially related to cardiac and non-cardiac issue, is they can manage so many patients at the same time. Typically, on the average, the virtual ICU can easily manage 100 to 150 patients at the simultaneously. It's not they're looking at every single thing, but the data is coming to them. And they can help triage those data points, and they can escalate to the bedside team. Because remember, the bedside time is not stuck looking at the monitors. It is a virtual team which is getting the data feeds and algorithm which is highlighting. So time zero and onwards, and that allows them to put them on ECMOs, come off ECMOs, wean off drips, get them extubated. So I think that's a fabulous tool. Again, protecting the healthcare team, minimizing PPE.
Perfect. And how have you worked out the logistics for this, particularly from a credentialing documentation perspective?
So, you know, advantage is that in Texas, if you're licensed, you can do that. And in other states, typically in a broader in virtualized setup, which they have multi-state, and the requirement typically so far is still to get licensed in each state that you're practicing. And typically we would require, and just like others would like, that the physician should be credentialed. The way we look at it is that the critical care physician is doing everything any other critical care physician would do except the procedures and the physical examination piece. So they are practicing medicine, they're making key decisions, so they have to be held accountable the same criteria as a bedside physician. What that does it creates a same level field for everybody.
Finally, any potential pitfalls that you've encountered in your setup and you can advise to other places looking to do the same?
What I would tell you is in our journey, just like many other institution journey of integrating virtual ICU, you have to do a lot of groundwork. You have to work with the bedside team, the cardiologists, the surgeons, the nephrologists, the primary care. You have to show them. Or not only that, but you have to work on a lot of nursing. This what I would say used to be called as a new way of doing things, but now it is a routine way of doing things. However, this is a big jump in how we practice. We are so involved in touching people and managing hands-on. This is also the same thing, except we are not touching. So, get them to the virtual ICU center, show them all everything, open to all changes. And I can assure you, when people see this thing and have our bedside along with the virtual team, they feel more confident. And technologies are also inspired that you can send a link to the consultant and they can see the patient along with you. So I think, having the bedside nurse and physician on board is the most paramount, because no technology can overcome, if there is no buy-in from the bedside team.
Absolutely. It sounds like the future is now and the future is here.
Yes, I agree with you, because what most of the places are seeing, and even our institution, is what we thought will take 1 year of buy-in and integration is happening over weeks. In fact, there are more demands and more integration that we could possibly think, and there are more requests to expand. And I think that's good, because that allows more tools and more management, and especially in a pandemic situation like that, you bring the expertise to the patient, and that is remarkable.
Absolutely. Thank you so much, Dr. Masud, for sharing your input with us and for your time in providing us with these details.
Thank you, Dr. Saeed, giving me the pleasure to talk to a broader audience. And, we welcome all input, and thank you.